Good morning everyone. Today we have part 2 of our chest CT cases review. We will discuss two cases of common chest neoplasms. Case number 1. We will review the case first. Actually, it is a simple case. The diagnosis is simple and easy for any radiologist, but here we can learn how to manipulate or evaluate such case, search for findings and report them. The pathology is very obvious. It's here, this mass lesion. What's striking about this mass lesion is it is totally solid lesion without internal air bronchogram. This is very notorious for lung masses, for neoplastic lung masses or bronchial carcinomas. It's very important here to notice the bronchial relation of such mass. If you can trace with me, this is the upper lobe bronchus. You can see this apical bronchial division, which is entering the mass, then it is amputating like this. So this mass is arising from the wall of the bronchus or around the bronchus with marked mass effect upon the bronchial lumen in the form of amputation of this bronchial division. This mass lesion, it also approximates the hilar lesion. You can see this component in the hilar region. If you can trace with me, there is communication between the mass lesion and these components in the perihilar location. It is abutting the origin of the upper lobe bronchus. Let's see the exact location of such lesion. In the coronal section, it is apparently occupying the apical segment of the right upper lobe. You can see the direct extension of which towards the hilar region. Also here you can see this amputation of the apical segment's bronchial division. One of the reporting criteria here is to measure the distance between the most proximal part of the lesion and the carina. It is actually reaching the carina, so there is no distance between such lesion and the carina itself. After you diagnose such lesion, you notice its shape, its bronchial attenuation, its distance from the carina. You can measure it in 3D dimensions. Then let's go to the mediastinal window, to the lung window, to see the borders of such lesion. You can see the lobulated border of such lesions with spiculated reactions and this small spiderweb appearance or pleural tags, what's called pleural tags. It is a sign of aggression of the lesion. It is a direct invasion of the lesion towards the nearby parenchyma and even reaching the pleural surface. This is what's called pleural tags or pleural tails. This is a site of continuation, site of contact, between the lesion and the fissure. You can see it is bulging the fissure, even it transfixing the fissure towards the apical segment of the right lower lobe. opposite to what we have seen before in the chest infection, where it respects totally the fissure. In the axial section as well, you can see this is the fissure, and this is what's called contact surface length with the fissure. It's considered as a pleura because it's lined by the pleura also. You can see the distance, it exceeds 3 centimeters. It is in direct sign for pleural invasion as well. So this lesion has indirect sign of pleural invasion. You can see the surrounding of the lesion. Sorry. The lung is totally unclear. There is septal thickening around it. Look at the difference, the asymmetry between the right side and left side. Also there is bronchial wall thickening here. This is called lymphangitic spread of the tumor. Lymphangitic spread of the tumor. So we have a lesion occupying the apical segment of the right upper lobe, measuring in 3D dimensions. It amputates the apical segmental bronchial division. It shows lobulated outline with spiculated reactions and desmoplastic reaction. It is surrounded by bronchial wall thickening and interlobular septal thickening, denoting lymphangitic spread. It is bulging the underlying fissure towards the apical segment of the right lower lobe, and it has a more than 3 centimeter contact surface length, denoting pleural invasion. In the lung window as well, you have to notice if there is any nodules in the same lung or in the opposite lung. There is nothing actually. These are atelectatic bands. Let's go from the stano window again. In the next step, you have to search for metastatic lymphadenopathy. We have to start to search well. You can see this fullness. This is a pathological interloper node, and we have also this node, nodal lesion, parting the atrium. At the subcarina region, there is no significant pathological lymphadenopathy. At the pretracheal region, there is minimal soft tissue fullness here. It could be continuity to the original mass, or it could be a small lymph node. You have to go up till the level of the supraclavicular region, because this is a site of pathological lymphadenopathy as well, and it is also a cause of non-regional metastatic lymphadenopathy, M1. You can see this lesion. There is soft tissue fullness here, which is encasing the vessel. This is actually pathological left supraclavicular node. The prevascular region and the orthopulmonary region are clear. Lastly, you have to search for metastatic lesion. Simple in this case, we have multiple focal lesions studding both hepatic lobes. They are liver deposits. What about the adrenal gland? This adrenal gland looks well. The other one. Just below the adrenal gland we have something here. It's also pathological nodes in the upper abdominal region. This is also a non-regional lymph node, M1 stage, beside that of the liver, of course. You can see the bone, we have multiple lytic lesions widely dispersed in the examined skeleton and spine, also bone deposits. Finally, we have an incidental finding here, which is anatomical variation. This is an abnormal location for the right subclavian artery originating from the arch of the aorta retroesophageal. This is what's called apparent right subclavian artery retroesophageal. Its anatomical variance. Case number 2. Despite being a non-contrast case, but it is easily diagnosed. Strikingly, we have a generalized lymphadenopathy here. You can see, starting from the lower cervical region, passing by the supraclavicular region, prevascular region, this is the arch of the aorta, aortopulmonary region, pretracheal region, and lastly we have large subcarinal lymphadenopathy, also bilateral hilar lymphadenopathy. You can see also small lymph nodes in the axillary region. Actually, they are non-specific, small to be characterized. We have also cardiophrenic nodes, periesophageal nodes, upper abdominal nodes, in such case, because of the affection of the hilar region, we have to put a differential diagnosis of both lymphoproliferative disorders such as lymphoma and sarcoid disease. What can help to differentiate actually? What can help to differentiate first of all is the age and sex of the patients. If she is female in young age or middle age, we have to suspect sarcoid. If we have more predilection for the hilar region rather than the mediastinal region or generalized lymphadenopathy, it will favor sarcoids. The presence of calcification would raise the possibility of sarcoid. What can help also is the size of spleen and liver. Definitely we have hepatomegaly. Also we have splenomegaly. This is more with lymphoma, but it could happen with sarcoid as well. Actually, in such case, we have nothing to differentiate. We have generalized lymphadenopathy, not only hilar. We have hepatosplenomegaly. We don't have calcification. So till now we have equal possibilities for the lymphoma and sarcoidosis. So they have to be put in the differential diagnosis list, and the pathology will differentiate between them. Let me show you something at the end which could help. It is actually the lung window. We have to search for any parenchymal manifestation of sarcoidosis such as fibrosis or like this, nodules. In this case we have many nodules, numerous nodules studying both lung fields. Some of them are clustered like this, or like this. This is known for us chest radiologists as what's called galaxy sign. This is much more with sarcoid disease. So despite we have nothing but this, we can raise the possibility here of sarcoidosis versus less likely lymphoma still for pathological evaluation. Thank you.